for our next speaker, we're going to talk about how some of these different payment models have been implemented in 2 different states. The first of them we're going to talk about is Massachusetts, and I'm pleased to present Katharine London, who is principal at the Center for Health Law and Economics at the University of Massachusetts Medical School.
I'm going to talk, my part of this after this morning's session is a little bit more technical than what you've heard. Although I actually am also a patient with asthma, and I have a child with asthma and experience many of the same stories as Jim Flood described. So I actually have a very strong personal investment as well, even though all I can do on this side is the numbers and not the actual patient care. Darshak talked about what these alternative payment methods are that are being developed around the country. I want to talk a little bit about what we're implementing in Massachusetts, some of the opportunities that these alternative payment methods provide for funding innovative service models, and also the challenges of implementing these methods. So Massachusetts in 2012 passed a health reform law that has a goal of containing costs. And the way this law works is that it establishes a statewide benchmark for growth in total health expenditures. And if the total health expenditures for the state exceed the benchmark, the state looks at every healthcare entity, every healthcare provider, every health plan. And if a healthcare entity's costs are high relative to its peers and its cost growth exceeds the benchmark, then the state can require the healthcare entity to submit a performance improvement plan. And if trends don't improve, the state can impose fines on that healthcare entity. And the way that the law anticipates containing costs is moving towards these alternative payment methods, away from fee-for-service, towards payment methods that reward quality outcomes and greater efficiency. And in particular, the method requires the Massachusetts Medicaid program to make 80% of its payments using alternative payment methods by 2015, which is very soon. So Massachusetts Medicaid has developed a number of initiatives that work towards providing these innovative care models for particular populations using alternative payment methods. And there are a whole bunch of different initiatives around care for disabled people, elders who are eligible for both Medicare and Medicaid, children with severe and persistent mental illness, people with chronic care conditions. But what I want to talk about today is the Children's High-Risk Asthma Bundled Payment Demonstration Program. It's a bit of a mouthful. We refer to it as the CHAPI, which is sort of an acronym of all of that. And all of these programs use this idea that we're trying to provide more and better coordinated primary care, preventive care, in order to prevent hospital care, which is more expensive and more traumatic for the child. And if you look at the cost, we might know that the cost to Medicaid for an inpatient hospitalization for asthma is about $6,000. For an emergency department visit might be $1,000. And preventive care for a whole year might cost $600. So you look at this and you say, oh, great, $600 is less than $1,000. $600 is less than $6,000. We should give this preventive care to all of our kids with asthma. Well, it turns out that if you take this broad-based approach and you give the same bundle of preventive services to all of the kids with asthma, your preventive costs are very, very high. And even though your hospital costs come down a fair amount, we hope, the total costs go way up and you exceed your budget. And as a state Medicaid program, you just can't afford to do that. And as a provider accepting one of these alternative payment methods, you would lose your shirt when you're taking risks. You can't do this. So what we need to do is think about how to target. We know that in healthcare, 20% of the patients generate 80% of the costs. And in fact, 5% of the patients generate about 50% of the costs. So the trick is to try to identify which children are most likely to require this expensive hospital care if they don't receive the preventive services, and to try to identify those children before they end up in the emergency room, before they end up in the hospital. And it turns out that this is really hard to do. And I think that this is actually really the hardest part of this whole change in the delivery service and the payment system. So what we did in Massachusetts, we spent a lot of time talking with our advisory committee about how to target these funds. And what we came up with was two different criteria. One is that the children had to have high-risk asthma, the most severe, as described by Dr. Keller before. And we described this as children who in the last 12 months have had a hospitalization, have had emergency visit, have had an observation stay for asthma, or have a prescription for an oral corticosteroid. So that's the high-risk aspect. But then we decided that actually that's not enough, because actually many of those children have very well-controlled asthma, and they're, they have all of their medications and they know what to do, their families are set, they're fine. So we wanted to look also at children who have poorly controlled asthma. And so those are symptoms like waking up at night with asthma, experiencing frequent shortness of breath, missing school days because of asthma. And those are symptoms that we can't pick up through a Medicaid administrative claims system. That's symptoms that the clinician can ask about in the office. You can call the family and find this out, but we can't do it administratively in the Medicaid program. So this required developing a program that allows the clinician to enroll children into this initiative. And that's a very different model than what state Medicaid agencies are used to. Usually Medicaid programs select people for particular programs based on their own data and enroll them. So establishing a protocol that allows the clinician to identify and enroll children in these initiatives was a big change. And a further challenge for state Medicaid programs, as most of you know, state Medicaid programs need to get approval from the federal agency, the Centers for Medicare and Medicaid Services, for most of what they do, either through a state plan amendment or through a waiver and very detailed protocol documents. But CMS, these kind of programs are very new to CMS, and CMS is just in process of developing a standard way of evaluating them, and there isn't really a process for small tests of change. So our process of working with the federal agency was very much one of learning together how to approach these issues and how to work through all of them. But the number of questions that come up, this targeting that we talked about, how do you choose the children to be enrolled? How do you let them know that they're enrolled? How do you determine what services they're going to get? How do you develop your budget? How do you ensure that the provider is not paid twice, once through this bundled payment method and another time fee for service, if you have that continuing also, or through one of your other many initiatives that Mass Health has? And how do you know in the end that you in fact improved outcomes and that you contain costs? How do you know that you have a positive return on investment, which we're required to do by Massachusetts law? So all of these questions required a fair amount of planning, and we've been working through it for quite some time. But I'm very excited that we've just received approval from the federal agency, and the program will be launching shortly. And I hope to be able to report to you soon that it was very successful in improving outcomes for these children.